Welcome back to the Pillar Kinetic podcast. I'm Dr. Minia, and today I have with me Dr. Joe. And we're here to talk a little bit more about how he treats shoulder pain. So as one of the co-owners of Pillar Kinetic, can you just give me a little bit of history on treating shoulder pain here at the clinic and your experience and how you got into that little sub-passion of yours?
Yeah, so when we first started, we worked out of a lot of gyms in the area, mainly CrossFit gyms. And you do shoulders every day in that type of setting. And typically people that are more athletic, you're going to see you're going to see shoulder pain more prevalent in that population. So if you have people that are, like anyone can really have back pain, right? Like anyone that's like sitting on a couch all day watching Price is Right, like they're not really working out, but they could still have back pain, or somebody that's lifting barbell could have back pain. So obviously we would see those things. But when you have someone that's really active and using their body, like shoulders and arms are used extensively in sport. So it's very common that people would have something going on with their shoulders, especially when we're in the gym setting.
Okay, so for people who are a little bit more active, the shoulder joint might be a little bit more at risk for painful things. So can you just talk me through like basic shoulder function and why that might be?
Yeah, so your shoulder's a pretty interesting joint. The main bony connection is really your collarbone attaching to your body. And then that attaches into your scapula, which attaches into your humerus, or the bone that's in your arm right here. So the muscles and connective tissue like play a big role in like how your shoulders are positioned on your body. And then just with how people positionally have to do things in their daily life, or maybe whatever sport they have, if it's pretty dominant in a certain position with your shoulder, that can have an effect on how the shoulder even sits at rest. And then as you're like raising your arm overhead, your shoulder blade actually has to rotate and move too. So about a third-ish of the motion of your arm coming overhead would be your shoulder blade rotating your body. So sometimes people are a little bit weak in those muscles that help turn it, or they're very stiff in that area. So they have to get too much motion from the ball and socket joint, and then that can cause some pinchy stuff going on where they're in the back of the shoulder or front of the shoulder, maybe when they reach behind them. So a lot of it is like, they could be weak in some things and stiff in other things, even at the same time. And then that causes things to rub into each other that really shouldn't be rubbing. So it's kind of like if you had a door that was not completely centered on the frame correctly, and you're like opening and closing it, you start seeing like all these splinters and sawdust coming down. There's really nothing wrong with the door or the frame, at least not yet. It's how they're interacting that's the problem. So then a lot of it is like you're trying to make things move around each other a little bit better.
Yeah, so you're saying like the movement tends to be the problem a lot of the time, rather than like people always want to be like, learn the answer to why they have pain with like imaging, but oftentimes that won't tell you very much.
Yeah, so the movement could be secondary to being weak or stiff in something. Like that can definitely alter the mechanics of what's going on. But imaging is not normally going to show you that, especially if you're getting imaging while you're laying down. But it only hurts when you raise your arm overhead or when you throw a baseball. Well, if you're not doing that in the MRI machine, you're not really throwing a baseball. So you're not going to see what's happening movement-wise. So that MRI can rule out things, but it can't like rule in things necessarily.
So besides like seeking imaging for all the answers, what else do you think people get wrong when they try and treat their shoulder pain themselves?
I'd say the first thing is not treating it. A lot of people just are like, oh, I'll just put up with it. Or sometimes my shoulder hurts after I do push-ups or something, or they'll kind of blame it on the activity that they're doing. But then, they just touch the front of their shoulder and it's like really already pretty tender and painful. That's probably something you want to get addressed. If it's like at rest and you haven't done anything for 2 days, and you touch the front of your shoulder and it feels like really hot or like someone's stabbing you, like there's probably a time to do something about that. As far as the things that they get wrong with it, I would say a lot of times people just try to like outstretch it. Like they'll just pick some stretches that they find arbitrarily speaking and just start pulling on things that feel tight. Well, there's more than just muscles that live inside your shoulder. So the stretching might help some things, but it might not take everything off the table. And some things it will definitely make it worse.
So what else lives inside the shoulder besides muscles?
Well, the bones are attached together by like a ligament type connective tissue, so like the joint capsule, and there's fluid in there, and the fluid moves as you're moving around. So you think if you're taking a water balloon and you're like squeezing it, like water goes the opposite side of the pressure. Your joints supposedly function in a similar fashion. So you're like moving one way, the fluid might move around the joint. If things are a little bit stuck, that might not be able to transfer. It might be a little bit stiff, like in that joint tissue alone. And that alone can account for like up to half the range of motion loss of a joint. Could be just the joint capsule being very stiff and stuck. And that's often when people can't really describe why it feels tight. They'll just say it feels tight, but there's like nothing pinching. It doesn't feel like it's getting blocked by anything hard. It just they can't really articulate like what's happening. They're just like, it just feels like can't really move anymore, but it doesn't really hurt at that end range, or sometimes maybe it does. So joint capsule is one thing that lives in there. Then you have the muscles, obviously, that overlap and become tendons as they cross over different areas of the joint. Then you also have the nerves. So like nerves fish and feed through there. And one thing that I've learned more and more over time is that a lot of orthopedic things will have at least some component of nerve involvement. If nothing else, you at least have to clear it. So what I mean by that is like, nerves carry signal like from your brain to your body and from your body to your brain. So it's like the wiring that helps that communication occur. So if they're getting compressed in any way, that can mess with the signal. It can send pain downstream. Like people can have pain in their fingers because they have a stiff shoulder. And a lot of times those connections aren't really made. It's very common when people have like wrist or hand pain or elbow pain. A lot of times what's happening is the nerve upstream is either getting compressed a little bit or it's getting accidentally lengthened. So nerves don't really like to be lengthened or stretched. They more so slide and glide through their channels up to like 3 or 4 centimeters. So if I had my arm like out to the side and I'm pointing my fingers down, the nerves are actually starting to slide towards my fingers, like through my shoulder like this. Well, if this is really tight and stiff and in a position where you can't get the nerve to actually like move through its channel, it's like like you're trying to pull a hose and one of your friends is standing on it. It creates a lot of friction, and even a 15% increase in the length of the nerve can be enough to cause pain and symptoms downstream. So sometimes that can happen like locally where the nerve's actually getting irritated. Sometimes it happens down at the wrist or fingers. So sometimes, and people will have things that are seemingly unrelated. Like they're like, I wake up in the morning and like these 2 fingers are always asleep. And then, but also my shoulder hurts. But those are definitely not related because those things don't ever talk to each other. But very likely that that's related if you have those 2 things going on.
So with all these different tissue types, you've got bone, muscle, joint capsule, nerves. How do you know where to start when someone comes into the clinic with shoulder pain?
So one of the first things we'll normally look at is positionally speaking when they have pain, and that can tell you a lot. So just like asking people what's wrong, like they'll pretty much tell you if you're really good at getting the questions out of them. So if someone comes in and they say, well, it hurts when I bench press. When? Like at the top of the movement, at the bottom of the movement, like when you're pressing the weight up, when the weight's coming down. And a lot of times people have to think about it because they've never really considered it. They like maybe nailed it down to this movement is what hurts. But then we ask them when during that movement, then they actually have to think about like when is that actually irritating. So if it's at the bottom of the movement, your shoulder has to be able to like your elbow will pass behind your body. So your shoulder has to like roll backwards or it's rolling backwards in the socket and it's rotating in a little bit. So if they say they have pain at the bottom of that motion, those are the 2 components of movement the shoulder has to do in order for the weight to come down and not be painful or to initiate some kind of a compensatory pattern where now they're dipping their shoulders forward because they've literally ran out of room for their shoulder to roll in the socket. And then it gets back to moving through the shoulder blade like we talked about earlier, where now the shoulder blade has to glide up. But that majorly like overloads the bicep tendon. You can imagine if you had a rubber band across the front of your shoulder and you're pushing your shoulder into that rubber band with every rep, you can imagine that's putting extra tension on the bicep tendon with every single time you bring your arm behind you. So you mix that with like high volume and it's just like rubbing 2 dry sticks together, trying to start a fire. So yeah, you ask them, positionally, when does this bother you? And then they'll tell you. And then now during the evaluation, certain things you'll definitely have to check movement screen wise or me manually testing their range to see if does that reproduce your pain or does it feel really tight to you? So sometimes it might not hurt until they are bench pressing like 150 or above, but it might also already be tender to the touch or might feel really stiff one side compared to the other. And that's normally a huge red flag that this is part of the problem that needs to be addressed.
Is there a hierarchy or anything like that you use as far as treating shoulder pain?
Yeah, we're big fans of Kelly Starrett, the Becoming Yourself Leopard. He did a phenomenal job of the test position, like I said, for the bottom of the bench press. It's one of what he would call like an archetype position. So if you're an athletic person, there's certain positions you should be able to be in. And if you cannot be in those positions without some kind of compensatory movement or pain or symptoms, then that's telling that needs to be improved. Like if you don't improve that, then what are you even talking about? Because it's such a glaringly obvious thing. It's like driving with the parking brake and check engine light on, and then you're gonna somehow like out cue that in the gym by someone telling you something verbally, or you're gonna like stretch something and then all of a sudden that goes away. It doesn't really work like that. You more so have to restore those positions. And just what I found is until they can do that position, like the likelihood of having other symptoms downstream can be pretty high. So like I've seen people have numbness in their hands or a weakness side to side where one arm fatigues faster than the other. And then this side's missing the ability to get their arm behind them. And then you clear that up, and then all of a sudden that weakness went away. So that was either clamping on a nerve or blood vessel potentially, where now as they're doing reps, then they need to get more oxygen and blood flow to the tissues. They wear out faster because like if the vessel's getting clamped on, it's got a narrower shipping lane to get the oxygen nutrition where it needs to go. So yeah, I would say you should be able to get in these positions. Can you do it? Yes or no? And if you can't, then we go by through tissue type to figure out why. Normally starting with more of a joint capsule first approach, because you get the biggest bang for your buck movement wise. If half the range of motion loss of the joint could be, half the range of motion loss could be in the joint itself. Like just start there. And then a lot of times it already feels better on the first visit. A lot of times people like minimum 20 to 30% better after you mobilize that on the first visit alone. And then you can also very easily teach the person to do that on their own. So using some kind of like a larger like jump stretch band, putting those across the joint, that's the equivalent of us like teaching somebody how to do like manual therapy on themselves. So like me, like gliding their shoulder in the socket to adjust the joint, like you can do that on your own with tools that you find in like any gym.
So as far as the archetypes, you already mentioned the archetype of a patient who has pain at the bottom of a bench press. What are other positions that people commonly have pain with that they shouldn't have pain with, or other archetypes?
And there's a list of them, and for anyone that wants to know like all of them in great detail, I definitely recommend Kelly Starrett's book, The Becoming a Supple Leopard, because he's the one that invented all these positions with the names, I guess you could say, or invented the archetype names. But another one would be like you should be able to have your arm straight out in front of you, and a lot of the archetypes will have either a straight arm or like a bent arm position to them. So like you should be able to raise your arm all the way overhead without any kind of elbow bending type position. The hang, your arm should be able to rotate in its socket without the shoulder dumping forward. So it's positions that you would see, like if you saw anyone do any kind of gymnastics or barbell movement, the components of that movement are probably made up of archetypes, especially at the like end ranges, the different positions you need to be in, or it's a combination of maybe some of those archetypes.
Gotcha. Okay, so you have these different archetypes and then different ways you can treat the different tissues that could have issues. So how do you take that information and then get someone back into the gym?
So when we do the initial evaluation, when we first meet them, you'll see what their capacity is. Like, what can you currently do right now? How well can you do these different positions or shapes? And if they can't do that, then that's very telling. You need to improve it, especially if it's different one side versus the other. And then we go through the tissues like we explained. And then from there, it's like, well, what do I do now? Like, so now if I can get to this position pain-free, like, do I just go back in the gym at 100%? Well, you'd want to start at a lower percent. It also depends on like how painful the movement was for the person, like when they're starting off. But it's kind of like a crawl, walk, run type thing. So if it like hurts when they're doing, like 20 air squats, well, you probably would want to do less than 20, and you probably would want to find a way of making that a little bit easier or unloaded. So you could shorten the range, or you could offload and do like a TRX or a ring squat. So that way they can offload some of their body weight and still work through that movement. You definitely want to eliminate speed. So like intensity or like quickness or explosiveness of a movement would be something you'd want to go into last, just because that it's a huge spike of force that goes through the tissues. And as they're trying to heal, like that could like re-damage it. So you can imagine if you had like a scab on the back of your finger, if you were bending it a little bit, you might be able to get away with bending it where that wasn't too much stress on the tissues to rip them apart. But if you just did it really fast, that might be enough that would actually rip it. Like it was too fast for what those tissues can handle.
Ouch. So
when the inside of your body's healing, you want to think of it as a similar way. Like the tissues have to spend a little bit of time mending, but you want to put enough stress on them where they grow, but not enough stress on them where they get re-injured. So like if you have knee pain and you just get out of the point where you can do like a weighted goblet squat with like 25-pound kettlebell, and you can just do that and not have pain, like maybe you don't go sprinting yet. Like there's going to be a big gap in between those things. You'd have to do other things, check some other boxes before you can get there.
Do you find with your population that is more of that like high activity level, more athletic in the gym a lot, they have a hard time scaling back because they really like their workout intensity?
Yeah, that's one of the trickiest things about treating people that are higher performers, that they want to get back to the gym. And obviously it's fun, they want to be around their friends and they don't want to be feel like the hurt kid doing stuff over in the corner by themselves. But we try to keep it as close to the gym activities we can. So the things that they're doing, you could probably still do those movements and just find a way to scale it, but it also depends on how long they wait before they get help. I mean, if they wait till it's painful to the point you can't lift your shoulder, you're probably not going to do anything that looks like shoulder press right away. You're going to have to get out of pain first. Mm-hmm. So you want to make sure that you want to try and keep them in the gym the best that you can. And if you just stop doing anything, you're going to get weaker. And then that's going to cause another host of problems that you're going to have to now come back from. So you want to do the things that you can do, but you want to be mindful of it not causing additional pain. So how we look at that for can I do this, yes or no? It's if you can't do that, if you do that, whatever you're thinking of doing, the next day it's a 2 out of 10 or less pain, that's probably okay. Doesn't mean seek that, go to a 2 plus out of 10 pain. It's not what that means. It just means if you wake up the next day or two and it's around a 2 out of 10, it's probably okay. But if you start getting more to a 5 or 6 out of 10 and creeping up the pain scale there, 0, of course, being 0, no pain, 10 being honey badger chewing your leg off kind of pain, you'd want to make sure that you're able to not hit those higher pain points because your body's trying to scream at you that you're probably doing more damage than good at this point. So that's, a lot of people say that they want to push through it or no pain, no gain. I think they're misinterpreting you could persevere through tiredness and fatigue and that could be considered painful, but you're not really running into a brick wall would be painful too, but that's not something that's no pain, no gain kind of thing. So if you're working out and you're re-injuring tissues to the extent that you wake up and your shoulder's on fire, that's too much. Whatever you're doing, you have to scale that, work on improving those joint mechanics and other things we talked about in order to get out of pain. But an important thing to also consider is when there's an absence of pain, when pain first starts going away, it does not mean I'm 100% healed. It's not like an on-off switch where you have pain or you don't have pain. It's more you do the right things, your body rewards you by reducing the pain signal, but that you have to then gradually test, going into that movement that was painful, not jumping right back to where you were previous because those tissues are still healing and mending. So it'd be if you had a scab again. If you're picking at the scab, it's going to be painful and it's going to prevent it from healing. But just because you don't pick at the scab for 2 days and the scab's still there, it doesn't mean you're good to rip that thing off. Mm-hmm. Inside your body is the same way that you would have to test it doing something lower impact, preferably slower for the movement too. Mm. So back to the knee pain example, if you're having knee pain with squatting, you'd want to be able to do that maybe in some offloaded fashion first, where you're doing rings or TRX squats nice and gentle, or you can do it to a box where it shortens the height and gives you a stopping point. Then you also know that that's the depth of the range you're continuing with. And then from there, you could gently start loading that, but keep the rep scheme low. The reason for keeping the reps low, and I would actually rather have people add a little bit of weight first as they're trying to challenge us than add volume, because you can imagine, let's say it's painful just through one certain part of the range. So if you're going slower, you might be able to adjust your body position just enough where you can much reduce the pain that you feel through that range of motion. But the other thing is back to the door analogy, if the door is running into the frame and causing a bunch of splinters and sawdust to come down, well, you wouldn't doing a lot of volume of that is going to be more friction points of the door and the frame interacting with each other. Mm-hmm. So instead, you'd want to keep the volume low and then just add more time under tension or slow the movement down. So it's still perfectly challenging, but you're not running those tissues together that causes that pain point over and over. So if you start maybe a 3x5-ish rep scheme, typically, depending on what volume the person was used to before, we normally start something low like that and then see how they tolerate it and let them report back to us. And if that's okay, then we maybe would add a little bit of weight with it, pending form and a few other things.
Nice, cool. Mm-hmm. All these analogies are super helpful to think about, I think.
Yeah.
I think overall picture between movement dysfunction, tissue problems, what would you say your overall approach is, if you could sum it up, and how it sets you apart from other physical therapists?
I'd say the overall approach is, when we look at a whole body standpoint of things, you do want to check and make sure other systems are not involved. So like people could have like a visual issue going on, and that could really affect like how well they're able to move.
Visual issue.
Yeah. So we've had clients where we've noticed, like they have the equivalent of something like a lazy eye going on, or you see, and they're like really spending a long time trying to focus on their phone, and then look up at you and they kind of squint for a little bit, and then like you can tell there's like something going on visually speaking. Mm-hmm. So then we can do some tests in the clinic to determine if that's maybe a factor. But imagine if you're having trouble with your eyes, like focusing quickly on a certain set point. Well, now if the person's like having ankle pain when they're like running, like doing shuttle runs and trying to do a quick turn, well, now when they're looking at that spot where they're trying to plant their foot, they might be getting a weird input from their visual system, or like their eyes can't focus quite quick enough, and their ankles may be getting a lot of variance in like how they're landing and where they're landing. So that might be something you have to address them and clean up. And we've referred people out for vision therapy multiple times where they had such a visual thing going on, especially if it's one eye versus the other, then they're going one direction. They might have to rely a little bit more on that other eye. And that was actually it was creating such a movement problem that we had to like help like get that taken off the table so they could like fully recover and know where they are in space and be able to be more precise with their movements and landing.
Not to get too much on a tangent here, but have you seen a case of shoulder pain that seemed to be needing visual therapy prior to physical therapy, or?
Not so much with, I'd say, like if it's there, you definitely want to like take that off the table for the person. I don't know if for that it would necessarily cause pain, but it might cause like accuracy issues. So if they have like a throwing type sport, or if they're like into shooting sports, and they're having trouble like focusing their eyes quickly and then near and far with like converging and diverging their vision, that could be enough that it could like throw their game off. So like from the performance PT standpoint, like it's hard to improve and fine tune movements if the person like can't see where they are, okay, or they can't quickly like adjust and accommodate for like where they need to be or where they need to look next. So those kind of things could be a problem.
Okay, cool. Super interesting to like have that little bit of background info on that piece. So just going back to my original question, you had mentioned that you taking like a true full body approach to it and clearing other things. So what other things might you clear that are important that maybe other people miss?
Yeah, since we call ourselves Pillar Kinetic, in the name, like we look at the pillars of health and pillars of the community, like that's the name that we gave ourselves because of making sure that people are hydrated, making sure that they are sleeping enough, making sure that they have good relationships, like that they have some kind of movement practice, like going through these different pillars of health. It's extremely important because like, let's say that we live in a desert. So like once or twice a week, they do some activity where they get super dehydrated. Well, some tissues like your knees, it could take weeks for the hydration level to return to where it was previous. And that's just after maybe a day or so of being dehydrated. Well, that's a problem if you have someone that has knee pain and they're trying to heal and the tissue that's injured doesn't have direct blood flow. It's going to get its nutrition and hydration from absorbing from other tissues. But if that's all dried out, I mean, it's not going to be completely dried out, but if that's lacking a lot of capacity or it's lacking the hydration to help buffer further friction, it's going to be hard to walk past that. It's like somebody trying to make strength gains and they're not eating enough protein. It's like, if you don't do this because of math, you won't have enough grams of protein to continue to gain strength or gain weight. So we like to touch on a lot of those things with our clients as we're going through their treatment plan, is we want to make sure that they have a good understanding that there's like other things that they can do too to help like offset that. Like if you're not sleeping well, that can mess with a lot of different things, but you might have a little bit more of a heightened nervous system response to things, like some things that might be a little bit more painful to you now just because you're so like out of whack from not sleeping as much. Like there's a lot of other things that can be confounding variables that can make it like the pain worse for somebody. And if they're not adjusting those things, then it's kind of like, well, like you have to take those things off the table too, to know that they're not part of the cause. So then after we go through the main movement screen and then like what positionally they can do and can't do, then we want to come up with a plan of like, this is how we're going to scale movements and this is what it should look like in the gym, depending on what they follow. So some people come in and do like 3 sets of 10 of certain exercises and they do more of a bodybuilding type, back and by chest and try split. They might do more of a HIIT class. So depending on what class they're in, that's going to tell you about how much weight they have to lift, the volume. Is it something that's dynamic where they might have to make some changes to their movements. So we want to come up with a plan that's custom based on the activity or goal that they're trying to get back into. And as we can incorporate like further classes and learning into our treatment style, we want to make sure that like we kind of bolt those things on those different sections. So you might have something where, you know, we take another class on something that's like a back pain type thing. Then you want to integrate that you can integrate it into that system. Like, so you should still be able to get into these positions, but now we have further tools and have built out, like, how would I, you know, add this into the back pain part? You know, we took a nerve dynamic course that was just about like how nerves move, how the sensitivity of them and all that. And that was completely eye-opening for stuff that we were leaving on the table before, because like we found out so many people have some percent of that it's almost like another movement vital sign thing you have to clear in order to say that they can get all the way like better. Like if that's still on the table, then it still could be a cause of it.
Okay, so kind of just like sum that up. We've got the movements that are painful, that matters. The type of tissue that's causing the pain, that matters. How to appropriately scale all of that, but then also looking at a little bit more of the whole person and their relationships, their diet, the sleep, all of this stuff, and putting all of that together will create like the best plan for someone coming into this clinic.
Yeah, that's correct. So you want to make sure that you have to check all the boxes, but also have a comprehensive plan of what's going on. So you know, it'd be difficult if we were treating like multiple people at a time. Like, you're not going to have the environment where you have the time to focus on all those different things. Like, you literally would have to give the person an exercise sheet and say like, well, good luck to you. And then everyone gets the same sheet because it's like safe and, you know, like low level exercise. If you don't do any exercise, low level exercise will make you probably feel a little bit better. But if you're someone that's like a higher performer and you already are in the gym, a lot of times you don't always really need to add more strength. Like, you don't need to necessarily build a bigger engine for the car you're driving. You probably need to like refine some things and maybe change a little bit about how you're moving. Like, it's much more common that we're actually working more on things that look like movement coaching, freedom mobility, breath work, those kind of things, because the person already is like plenty strong. It's just that they have to have a plan to get back to doing that pain-free.
Yeah, I think I find in my own practice as a PT, a lot of people think that it's just weakness, and finding the right movement can go a long way when it's not really a weakness problem.
Yeah, and you find too, like, people that are stiff, like, they want strengthening exercises, and then people that are like already very like limber, they want more stretching.
Yeah.
So it's normally they need the opposite of the thing that they want. But everyone, you know, people have like the same parts of their bodies and stuff, but it's more so depending on like their history of training and how they live their life, how they treat themselves. That can make a lot of changes to how you adjust somebody's program, because you have to make sure you're like meeting somebody where they're at and then making a correct path to the goals that they have. Yeah,
cool. Okay, I've got one more bonus question for you.
Yeah.
And now, as we're saying, we're not giving all our patients the same exercises, but I know as a PT, sometimes I'll hyperfixate on an exercise that I really like for more patients than normal. So I'll kind of give everyone this new thing that I like a lot. So is there any exercise that you've kind of hyperfixated on in the last month or two with your patients?
For any kind of like shoulder?
Any shoulder thing, yeah.
For shoulder things, I would say just like that green band backpack mobilization, where they have the band going behind them attached to a rig or pole. The band goes across the front of the shoulder, and they step forward where it glides the shoulder back in the socket. I like that for a few reasons. Like, one, if the person's laying on the table and I'm manually doing that and the person feels better, that's a way they can recreate that on their own at home. So now they have the tools to do that. But also, if they're intuitive enough where they can feel what it feels like to have their shoulder pushed back like that, now they know the feeling that they're looking for, and they can use that exercise to like get better at that almost as a skill. So we look at these mobility things and the things we teach our clients, we're actually teaching them skills. How does your body feel? A little bit of awareness kind of thing. But once they're able to get that down, then we can work on other mobility stuff and have further conversations, because now they understand the point of what they're doing. They understand what it should feel like, and it's probably giving them some relief already. So that's a really good starting point before we get into different directions. And I also like that because if someone's shoulder's kind of jammed and stuck forward, that can rob them of other directions. And then if you just force them in those other directions, it could actually become painful. So you know that that's the way that they're stiff. It might be that they're getting into the end range of what they currently have in that position. So by pushing their shoulder back in the socket, that'll open up enough space where now they might improve rotationally in multiple directions just because they got their shoulder out of this like stuck forward position. And I find as more people are on their phones and driving and everything's in front of you, that just getting out of that position is typically pretty helpful.
Wow, awesome. Well, Joe, thank you so much for speaking on your specialty, your expertise, the shoulder joint, and that's all we've got for today.
Thanks.
Yep.
Thanks so much for tuning in today. We really appreciate you spending time with us. If you found this helpful, please like and subscribe so you don't miss future episodes. And if you've got questions or if you're dealing with something that needs attention, reach out. You can email us at info@pillarkinetic.com. We're here to help. Thanks again, and we'll see you next time.